Good afternoon. We are now live from the Medical Education Centre here at Warrington Hospital, and a very, very warm welcome to the second of our special Grand Round series. As you probably know, we're focusing on COVID-19, and this week I'm really delighted to welcome Dr. Sagar Patel and Dr. Laura Langton, and they're going to be talking us through developing seamless respiratory care, so social distancing but working closer. So thanks very much, and over to you.
Hi, good afternoon everyone. My name's Dr. Laura Langton. I'm an intensive care consultant here.
So Sagar Patel, I'm one of the acute respiratory consultants here at Warrington, and Mark Forrest, one of the other ICU consultants, and isn't in today, I think, or is
No.
No, but
maybe on a helicopter somewhere.
Yeah.
So we're going to talk through kind of how we managed COVID first time round, the response we did, the challenges we had, what we learned, and how we're moving forward for the second wave, which we seem to be into. Yeah.
So bear with us. This is the first time we've done a Teams presentation over Grand Round, so let us know if you can't hear, see, or whatever. So there you go.
Yeah, lovely. So first wave, basically, we all know COVID we were starting hearing about it in January. February it was starting to get very, very real. And we had to, it became quite clear we needed to start planning for this. At sort of end of February, early March, as much as I can remember. From then we started planning. From an ICU challenge point of view, with consultant shielding, we needed staff. We needed staff 24/7, which we do anyway, but due to shielding, we lost consultants. We only were down to 5 consultants. It became clear this was going to be, London was starting to build. This was going to be a big challenge for ICU. We were going to need the staff. With 5 consultants, we would burn out. Staffing would go down. Some of us would get sick. How we were going to manage that. How we were going to manage our space. We actually have a big ICU. We have 20 beds. We're funded for 18, but we only have 2 cubicles. We were expecting more patients. Where were we going to fit this patients? How were we going to manage? It's not something we'd ever done before. Nursing staff, we were going to need extra nursing staff and extra healthcare professionals, physios, etc. Where were we going to get these from? How were we going to manage it? Equipment, we were going to need extra ventilators. Where were we going to get these from? Pumps, that was a major thing actually, not having pumps. Where we were going to, trying to source all these things. And I think, the biggest thing we had to deal with was fear, our staff. I certainly remember we sat in our ICU consultant meeting one Friday afternoon. We took a picture of ourselves because, we were hearing of consultants in China dying, anaesthetists dying. We've all got families that are shielding, fear of what we were going to see, what we were going to manage. A big fear of mine was, were we going to have to make really difficult decisions? Which I've only got 1 ventilator left, I've got 3 people. Am I going to have to pick who I put that on? It was all unknown. It was a very, very stressful time, but we pulled together as intensive care, and it was clear we were going to have to work very, very closely with respiratory as well. This was a respiratory disease. So solutions, so how we came out. We used our anaesthetic volunteers, so a couple of our anaesthetic colleagues, so Bruce, who's an anaesthetic consultant, volunteered to become an ICU consultant, and Pete, who'd done ICU in the past but had stepped down from the rota, stepped back up on the rota. This meant we had 7 people. We could run a 7-day service. We each did basically 2 days a week, time off in between, time off to just have some time off and not be in there. We planned for theatre pods. We were going, our plan was to escalate into theatre. Theatre pods meant we would have 3 patients in each theatre, so 2 in the main theatre, 1 in the anaesthetic room. Staffing those, we would have ICU nurses and then use theatre staff who, were phenomenal, stepped much out of their comfort zone and helped. It became very quickly apparent that we needed to cohort our COVID patients together, having patients all over the hospital when the main one of the main treatments is physios or seeing them. We needed them all together. We needed all the equipment together, all the physio equipment together, the knowledge together. So in the first wave, our COVID patients lived in the ICU, and we also had a level 2 area in recovery, which was a bit small, cramped, particularly in full PPE, hot, but it did work. It did work. And we needed to work closely with our respiratory colleagues, probably best for you.
So at this point, we kind of looked at where we could help ITU increase capacity. And the way we worked was, and we'll go through this in a little while, was daily board rounds. So quickly upstairs on A7, A8, and as Laura said, volunteers from A8 stepped right up, who weren't used to managing respiratory conditions, both nursing and medical and physio and healthcare assistants, and decided they would take it upon themselves and help us out. So we used to run a board round, and Laura found some very willing volunteers to help come to the ward every day to help. We then decided that the safest thing to do was, once Laura and her team and Mark and the guys had safely managed these patients, we'd try and step them down on A7 as quickly as possible. So hence the respiratory step down unit on A7 was born. Opened actually on Easter weekend. Always a nerve-wracking thing, opening something new on a weekend, but it was got to that stage where it just needed to happen. Patients were stepped out of ITU and continued their recovery on A7. And from a patient experience point of view, that really worked well, because they were back in a ward environment, they were cohorted in the end, they were by that stage talking to each other. So we had stages where patients were recovering, talking through their stories together, which I think psychologically in the middle of a pandemic where the patients themselves were fearful really helped us. And the feedback that we got when we did the step down unit feedback from patients was absolutely incredible, because they were able to share all of that kind of experience that they had gone through and the fear. And don't forget, they didn't have relatives to talk to at this time. So they're in ITU and they haven't had their relatives around. They come to A7, they don't have their relatives around. So I think whilst we did it for capacity, I think it actually won all round in terms of holistic care, which was great for us. I'll let Laura crack on with sort of the rapid training of her team that she had to undergo.
Yeah, I mean, so we first wave in a way was easier to manage. We got our first COVID patient one Thursday evening. We were waiting for it. It actually, I think we all felt a lot of relief that we'd got the first one. In a way, the wait was far worse. But it very quickly, as the first one arrived through the doors, things changed. It was clear we were going to have to redeploy staff, get them trained, nursing wise, physio wise. Alison kindly gave a couple of extra foundation doctors, so we could run an extra tier of on-call, so we had numbers on the floor. We had surgical trainees come and help us. It was, we had a lot of staff, all of which stepped out of their comfort zone and worked, really well. So we were fortunate from that point of view. So the initial treatment of COVID, what we were, we didn't have much information about it at the time. We know what was coming out of China was fairly scanty. We believed it was an ARDS, an acute respiratory distress syndrome. We discussed as an ICU how we were going to treat those first patients. We were going to ventilate. Everyone who came through the door, we were going to ventilate straight away. That's how we treat ARDS. That's what we believed at that time to be the best thing. Another big thing that confounded that, you know, going back about the big fear about aerosol generating procedures. So things like CPAP, high flow, we considered to be aerosol generating, and if we had patients on this, we were all going to get it. You know, ultimately we were fearful staff would die because we were treating them in this way. We had set training on how we would intubate these patients to manage that. Anaesthetist led that very much so. So there was a set protocol with our ODPs, how we intubate, how to minimise the aerosol generating procedure. We needed to make sure we minimise pressures and barotrauma. That's what we do anyway on ventilators as much as possible. You know, we thought that they were going to have very non-compliant lungs. That turned out not to be the case actually. Patients actually who were on the ventilator had very compliant lungs. We assumed we were going to have to do permissive hypercapnia, so let their CO2 rise, you know, as long as the pH wasn't affected too badly. Again, this was never an issue. It's always been a type 1, not always, but predominantly a type 1 respiratory failure, so low, so hypoxia. We were going to run them negative, filter as needed. We knew proning was going to be important, and we knew ECMO was going to have a role. ECMO centres certainly stepped up. We didn't actually transfer anyone to ECMO from our experience. In the first week, 10 days, it felt, it may have been longer. It was clear COVID was very different. The various intensive care societies, European Society, ours ones, were running webinars with doctors from Italy. And we were learning COVID was different and that actually ventilation probably wasn't the best way. Now, some patients it is inevitable, but ideal, you know, people were starting to see good results with CPAP. And that's where our black box thinking came into fruition, really. It became clear we needed to use CPAP. We'd been treating for a while, you know, PPE was clearly working. Our staff weren't dropping like flies, that was the fear. And that's where Sagos found a load of black boxes. So
this is really random. And this is where I guess the title from this talk, social distancing but closer working. Again, we use, so the black box itself is a CPAP machine, which is the same as the ones they have in IT, but same but different, if that's the best way to describe it. They're machines that we use at home for patients who have obstructive sleep apnea as a condition. The team over predominantly at Halton and some at Warrington in the cardiorespiratory department use them quite widely, and they're quite safe. However, the very big difference is they're not designed to run for patients that are very sick in intensive care. They're designed for stable patients at home who put them on themselves at night, take them off in the morning, and look after them themselves. So, sort of, as Laura said a few slides ago, the worry was, are we going to have enough equipment? And I remember very vividly that when the call came to try and look at these machines, I think you were isolating.
Yeah.
And
yeah.
Mark Forrest was also isolating. So when we talk about the title of this, social distancing but closer working, I remember WhatsApp calling, because that was before we all knew how to use Microsoft Teams, to Laura and Mark at home from the cardiorespiratory department just down the corridor with Joanne Coops and her team as to whether or not we felt this would work. I contacted a few of my colleagues at other hospitals, and they were sort of trying very similar things. So we needed to work out whether it would work. And whenever anything this happens, you need someone who is very clever and very good with numbers. And so we went to the anaesthetic department, because that's where they usually hang out. And I found a willing volunteer to help crunch some numbers for us. So we had to work out some basic stuff. These were machines that were safe to use. We knew that we could use them for this purpose, but was it going to be safe? And could we work out that they would work in an acute setting rather than just a stable setting? So we had a virtual sort of meeting and conflab from, first of all, the cardiorespiratory, then the anaesthetic areas. And we found a very clever man who can work some numbers for us to see whether our crazy idea was was true, and it was. And when we checked it with local and national other departments, they were doing very much the same thing. And I think at this point, I cannot really emphasize how important cardiorespiratory were at this stage. They probably in about 48 hours managed to find, I don't know how many we ended up with, but refurbished them, got them pack tested, got them checked, set the settings. I think they worked really hard over a period of 2 days to just get these things from Halton to delivered over at Warrington ICU ready to go. And then Jo Thomas and her team of physios had to get heavily involved in terms of the mask fitting. They were really going to be key to putting them on and off and making sure that they were working through the day. And then, as Laura's already said, rapidly training people. This was an old piece of kit used in a different way, and that needed training for people. So there was nothing that we couldn't do, but we just needed to check we were doing the right thing. And then there was a testing phase. I
mean, from a CPAP point of view on ICU, CPAP had kind of gone, really. You know, nasal high flow had come in that sort of superseded CPAP. So I think we had 2 proper CPAP machines in February. Clearly wasn't, it was absolutely necessary. And, and I think units across the country had the same issue. There weren't that many machines around. We couldn't borrow from everywhere else, because the whole country was in the same state. And
any stock you tried to buy, you got put on a waiting list with everywhere else in the world, because unfortunately with COVID, as you all know, it's a worldwide pandemic. So we tried in desperation to order, I think, well, everything, but
it wasn't going to come to 6-8 weeks time, and that was going to be too late.
It certainly wasn't from the Amazon warehouse down the road, was it? We were getting delivery schedules that weren't going to be okay for our patient population. Hence, we thought outside the box slightly.
And then, it became, so our first patient was actually a member of staff. And we put him on in a very controlled way. We did take him onto the ICU so we could monitor him properly. Not recovery had it, but it's just that little bit safer. Art line, full monitoring. All our patients on the black box had that. And again, Jo Thomas and the physio team came up with this CPAP weaning regime of how we do it. So it was very structured, very easy for nursing staff to understand what stage we're at. Patients can see it, they can see that they're progressing, we can see how they're progressing, but essentially we get patients, we put them on for CPAP, they basically go on for 24 hours with very minimal breaks, just for sort of comfort breaks and fluid, food. As we go on, those meal times, they have breaks, meal times, and they'll perhaps be slightly longer, and then again, so the next day those breaks sort of get longer, so the time off the CPAP gradually gets longer. Then you get to a stage where we're using the nasal high flow for most of the day, but we still get CPAP at night so we can rest them. And then we get to, and then if they're okay on that, we try for 24 hours on high flow, and that's when we start talking about stepping down to A7.
And that's where we sort of looked at how to create extra capacity within our specialist area. So a lot of hospitals tried to start mini ITUs dotted around, and I think the discussions that we had were actually, let's take them out the back end a bit quicker to free up the bed for the next patient coming through the door. And actually, again, if you get, I know it's an infamous term at the moment in the hospital, but if you get flow right, then we would always be able to create capacity for the next person at the front by clearing that one out the back in a safe and controlled environment. And I think when you talk about this sort of work, where we had people, and Laura and her team having people drafted in, and the respiratory team and the physios having musculoskeletal physios working on the IT, I think what we realised was having sort of a very structured approach was the way forward. And it's not to everyone's liking, but I think in hindsight, I think it's worked very well.
The numbers we had at peak, it was definitely.
So then we went on to the nasal high flow. So that was upstairs on A7. So they'd come from ITU on nasal high flow. So that was again the team upstairs of nursing got trained very, very quickly. So, we'd start to wean them in, and we used very much the same way that we would wean on the CPAP. So we'd start the flow rate high, we'd start to wean the oxygen, but keep the flow going. So these guys were getting sort of, if you imagine, 40 litres of flow through their nose in warm humidified oxygen. And so it gives them that pressure, it gives them a little bit of support with their breathing, especially in the early phases of mobilization. And I remember the first time we ran the morning movers. So we ran morning movers for these patients who hadn't done any exercise for 7 to 10 days. And we had Laura came up to the ward, and we had sort of on the bay of A7 at the back, we had Gary the physio and his team, Laura and I, and we ran a morning move. So we actually had them on their nasal high flow machines on sort of 40% oxygen and high flows. And we got them to do basic exercises in a very controlled environment about sitting up, standing, and it just got some of that fear factor away from the patients that actually they are on the road to recovery. And nasal high flow was in, but again, this was a machine that was at a premium. You couldn't buy them for love nor money around the world. They're produced in New Zealand, so even at the best of times, getting them over here is not easy. So we looked at just weaning them in a very controlled environment. So whoever came onto the unit, if they were one of the redeployed juniors that Alison, Jade, Robinson, Linda Henshaw, and all the team that had done all the rotors and managed to redeploy, they still knew how Laura and her team wanted things to move forward. I'll let you.
Yeah, so the other thing that quickly came out, we've known on ICU, proning patients helps with respiratory disease. It helps their VQ mismatch. The weight of the mediastinum comes off. You just improve a lot. So we're proned on ICU. We prone a lot more now. We've really learnt the benefits of that. But it became if proning works for ventilated patients, why wouldn't it work for awake patients? And so the evidence came out, and the whole sort of conscious proning came out from Intensive Care Society. And so we encouraged our patients to do this, and we get great results. We were seeing patients who would be on 70%, they'd turn on their back and they'd be down to 40. Onto their fronts, and then their oxygen would come down dramatically. And so this gives sort of a good guideline for patients to do this. And I think, motivated patients, they want to get better, they want to get home. This gives them some control over it. I've not got it, you had COVID, but if I get it, I am planning on spending 23 hours of the day at 24 on my front, because it just works. And the physios have been vital in this as well. So certainly when the patients are on CPAP, that looks very simple there. That patient's not on oxygen. When you're on CPAP and you've got an art line and you've got a cannula attached to fluids, your antibiotics are running, etc. Moving and doing that with all your lines, it just isn't simple. So we needed the physios to help position lines. If you've got a mask, where do you put your, how do you position your face? How do you make sure you're not getting pressure sores? So they were instrumental, and particularly some of these patients would be on 80–90% on the CPAP, and we were still forced, making them do this because it could make the difference between them not needing to go on a ventilator. So the first round, our results, we kind of knew we were doing well. We get data from ICNOP, the Intensive Care Network, and research. So this is our first wave. So we had 69 patients. Northwest, as a whole had more. We are currently in the second wave. Northwest have the most amount of patients, very much so. And I just wanted to look. I had a feeling we were doing well from early data coming from ICNOP. It seemed like our mortality rates weren't as bad. This was the final one from the ICNOP for first wave. Now, some of the Northwest, if you analyse it closely, don't quite add up. There's some missing data. that they've got, but we don't have missing data. But essentially, we ventilated about 50% of our patients, and 43% of those died. We were, you know, from the ventilated, we were doing much the same as everybody else nationwide, about a 50% mortality. That's the same nationwide. However, our non-ventilated, so our CPAP patients, you can see we did really well. So we only had 8.8% mortality. Now I don't recognise that our numbers are small, but it's significantly less than the Northwest. And overall, our mortality rate was much better. 74% of our patients who came through ICU, we managed to get better. And it's pleasing to know that, and I do think it's got a lot with how we organised it, and knowing what we learnt last time, we go forward to the second wave to try and replicate those results and hopefully get them even better. So it goes back to the sort of thing.
So going back to sort of that joined up thinking that we had. So your patient presents to A&E, and the A&E team did fantastic in terms of cohorting right from the front door. So Sally Richardson and James Wallace decided they were going to have A&E, respiratory high care, respiratory low care, different areas if they were query COVID. And that meant, again, you could focus your attention as to who needed to go where. That then spilled out onto the acute general medicine take, because these are all technically medical patients that came through the door. And the surgeons let us borrow staff, and we'll go on to thank a few other people that managed to hold the fort, because although we had admissions down, we were still getting GI bleeds and cardiac MIs, and there was the odd spattering of non-COVID patients taking up time from not only the general medics, ITU, and everyone else. Respiratory specialist services, patients were cohorted and moved very quickly based on whether they had COVID, whether they thought whether they were highly likely to have COVID. And also one of the things that we did, which was very different, was we cohorted very strongly. So we knew where we needed where we needed the correct services. They'd go to critical care, and then we've even gone as far as having rehab and follow-up. So I know that the physios are phoning these people at home after discharge to check how their rehab is going. And the key here is we don't want to complete the cycle. We want to discharge and rehab them and not have them reattend into A&E. That's the idea, to ensure that doesn't happen. So we really had to make sure that we didn't just get to the critical care phase or the respiratory specialist phase, discharge them and they're forgotten about. We needed to complete the loop almost. We didn't want to quite complete the loop for obvious reasons. And this is where Laura was saying about how did we get it right, or touch wood, how did we get our percentages up and our survival rates up? Well, we sort of kept it really basic. At 9 o'clock in the morning, there was a board round outside A7, A8 with critical care outreach. Identifying beds, identifying who needed to go where, what was going on. We'd inform the bed managers of patients potentially going to ITU, potentially needing step down. We'd give time for the clinical work to occur. So I think that was key. As much as we had 8 AM tactical meeting, a board round, we as nurses, doctors, healthcare professionals needed time to see the patient. So we built into our day, after we've done the board round and after ITU have had their handover, we are actually clinical now, and we're going to see these people and we'll reconvene. But I think the basics of knowing that we were going to touch base again at 12:30 meant that we knew that if we needed to escalate or de-escalate care, we could continue seeing the patients and use that opportunity to go from there. The other big thing that personally I think we've learned from this is retrieval teams. So, teams going to pick up the patient rather than having patients pushed upon them made a huge difference in terms of the fear factor. So as Laura said, the first patient that came to ITU, there's that fear factor, there's that, what are we going to get through the door? But I think, as we went on, we worked out that A7 staff going to ITU to pick up the patient wheeling them back meant that they know that what was coming before that happened, and crit care and theatres doing exactly the same thing. So looking at the second wave, we're trying to build on that in terms of retrieval teams and moving to virtual working in that way so that we can use that to our advantage. So, you know, manage the team, not the individual, was our way of going about. We wanted to manage the group of patients, each individual patient, but in terms of us, theatre recovery, A7, critical care, A&E, it was a team approach, and you know, you have to, at this point, I have to mention, you know, our gastroenterology and our endocrine colleagues that dropped what they were doing to assist in supporting that the respiratory team could concentrate on the respiratory element of COVID and those patients that were going to ITU and stepping down from ITU. You know, they engaged with learning about respiratory disease. Some of our gastroenterology and endocrine colleagues worked hard to understand different X-ray changes and where to look for support with regards to this. Fraser Gordon and his team on A8 dropped what they were doing and became a second COVID ward, which was absolutely crucial because the numbers were getting through the door. And, you know, it's not forgetting any member of staff that left family and friends to ensure they could be around. We've had consultants working here who sort of almost work like oil rig workers, 4 weeks on, a week of isolation, and then 2 weeks, 3 weeks with the family, and then back for another 4 weeks. And you know, that's a massive commitment in your life to ensure that we could work together. And I think that again helped us, is that you know, we knew we could rely on these people, and we knew that we could always get support from the meetings that we had in place. So, you know, just a massive thank you, I guess, from us to those people that helped in that regard. Going on to the joined up thinking. So we wanted to have a look at what we were doing, and we did this very early on. I mean, this is a screenshot of a slide, and we're not going to go through all of these slides in this presentation, but this happened, what, 2 months ago now, maybe? Yeah. And very quickly we started reviewing what we were doing. So, and as you can see from the names on that, there's 2 ITU consultants, there's a frailty elderly care consultant, and then there's myself from acute and respiratory. So again, looking at not just ITU, looking at what's happened, or general medicine, but involving a different specialty in the box as well. And what we needed to know was, were we escalating and de-escalating the right patients? Were we making the right decisions? Was everyone comfortable that, as Laura said, if we've only got 3 ventilators right, who do we choose? We needed to know that we were making the right decisions early on, especially if a second pandemic came. And what we worked out from this is, we looked at everyone and we triaged them: red, amber, green. Green was we accepted the decision between the 4 of us. Amber was we wanted to discuss it, and red was that we felt actually we may have made a mistake there. And we did this all individually. We did it all on our own and then looked at it together. So each person got a review, and we actually found out that on review we didn't disagree with any of the decisions about escalating care made by any of the teams involved. And I think for that was huge. In 112 patients, the 4 of us felt individually that the right decisions were made, and I think that was great for us as a reassurance more than anything that we were working well together. We did discuss one patient, and actually we all agreed in an MDT with, again, with different specialties involved, that the right decision was made. But it's no surprise that 1 or 2 we wanted to just have a chat as a group. And then obviously that left the 111 that we agreed with the decision about escalation of care. So Laura's just, I guess, going to chat a little bit about this.
Yeah, so, knowing, steep learning curve, what we've learned. So last week, our COVID numbers in ICU started to escalate again quickly. So as a ICU group, we discussed how we were going to manage them so that we have not a strict protocol, but at least something to work on. So we don't do weeks on, we do a day at a time, so that we're following the same process. So respiratory care at the front doors, the respiratory scene, decisions are made early. We can have a patient that you may have on A7 that we would take, but would only take for certain levels, etc. And so we're trying to make those decisions in daylight hours. You know, I'm not being asked to make that decision at 3 o'clock in the morning when I've been in for 14 hours in the day, and etc. We're trying to make that early admission to ICU. That I think that's made a real difference. We're getting, you know, if you'd have told me a year ago I was going to accept a patient up to an ICU for CPAP because they were desaturating on 40%, I'd go, no, repeat a gas in a bit, perhaps ring me back. You know, I'm not interested. But it's clear if we get these patients early and start them on CPAP early, we can stop them deteriorating. We can turn them around. Certainly in this past week, we've had a gentleman come early who was turned around in 48 hours, is back on the ward. Immediate CPAP, so you know the default is they come to ICU, we put CPAP on, we get lines in, we get, you know, and we follow the protocol we discussed before. We get them self-proning, we get them early mobilisation. So if they're not that keen on proning, can we get them sat out? That, you know, on levels of oxygen we would never normally think about sitting patients out on, we're getting them sat out. It seems to do them good. We start on antibiotics, so the trust regime of augmentin, doxycycline, but we check CRP, white cell, and procalcitonin, and we look at that. So we have strict antibiotic surveillance. We have a microbiology ward round daily on ICU, and we will stop those antibiotics if we don't feel there's any secondary infection, but we will start patients on it. Anticoagulation, that became a huge thing. We know this is, you know, basically a vascular disease as well with microthrombi. We had lots of patients who developed DVT in the early stages of the first wave. So we check a D-dimer, again, something I would never think as a ICU consultant I would check because it's always going to be raised. But we rationalise treatment. So if the D-dimer is greater than 3 or it's greater than 2 with risk factors, obesity, cancer, so on, we put them on treatment dose Clexane. If not, we have BD prophylactic Clexane. So that is an increased dose, and that comes from recommendations again from Intensive Care Society, because a lot of these patients go on to develop DVTs, PEs, and we figure that a lot of their secondary complications to COVID are probably microthrombi related. Dexamethasone, we all know that came out. We were part of various trials, recovery trials, during the first wave of COVID. We know that works, it's simple. So we start 6 milligrams, we have PPI cover. Carbamazepine is, again, Joe Thomas's recommendation. These patients often don't really have secretions, but it does help to bring those up. So we started that. And then we're 7% saline nebs for those patients that are intubated. We don't do those on awake patients because it's a bit unpleasant, but if they were sickened patients were to tolerate, we would consider it. And that's kind of our default COVID admission management plan as it stands.
I guess to end, we were going to put some names and then you always forget some names, but I think a slide that Laura put on a few minutes ago about how we've had numbers that are really promising within Warrington Hospital. You know, everyone made a massive difference. So, you know, cardiorespiratory and getting the equipment ready. You know, Laura and her team were relying on her cleaning staff, cleaning rooms around really quickly to get the next patient through the door. The catering team providing things on plastic plates so as not to cross in. You know, I think what sometimes we forget is those little changes that means that the cogs can run. So, you know, the porters and all that, moving people around as quickly as possible, being there in a rush, you know, transfer teams, pharmacy, you could sit here for a whole grand round just thanking people. But I think in order for us to present figures like we have, you know, social distancing but closer working, the teams, and I'm sure I will have missed one team on there and I will apologise now, but you know, I think that made a massive difference for us. So we haven't got the chat open. I think some of the IT specialists have, but if there are any burning questions, we can take them. I think there is an IT have set up a way for us to answer questions.
So thank you very, very much, Sarah and Laura. It's just amazing to hear about the team working, the collaboration, the professionalism and just the innovation that people have shown. We haven't seen any questions on the chat, but just maybe a final question from me. Is there anything that you're going to do differently this time?
So I think differently, one of the things that we have done is, so we now try and implement a respiratory ward round in ED every morning to make sure we mop up the patients that are downstairs to make decisions about who goes where. And I think partly I mean, I don't know, in terms of differently, we are looking at more virtual working. So I think there is a project ongoing about, you know, having the ability to do a Microsoft Teams meeting to move some of this stuff to slick up the process of using bleeps and things like that. We have equipment arrived that we ordered for the first wave that I think has now arrived. So I guess the big difference will be equipment that now has come. Yeah,
we shouldn't need to use the black boxes this time around. We've got a lot more ventilators, a lot more CPAP machines, pumps. We've got everything. We've run out of storage, actually. Yeah,
so finding some storage might be a big problem, but I think we're going to revert to what worked well and make sure that we go back to if we need to, where we really ramp up like last time, go back exactly to what we did, tweaking the bits that we need to.
Thanks. There's just a couple of questions come through. So somebody's saying, well done. Can you motivate staff to reproduce such excellent results again over a long, slow burn type of scenario through the winter?
So I think that, Alison, probably is the massive question. I know that, you know, Laura and I sat here, and I know that our colleagues are probably feeling exhausted and fairly tired. And I think Laura's first slide mentioned fear. And I think first time around, the fear between our team certainly was the fear of COVID. And we got over that. And I think the fear this time is, like you've just said, the long slog over winter. So I think we're not as scared of the disease as we were last time. I think it's the fear of
how are we going to cope. It's huge, and you know, this winter for me feels incredibly daunting. You know, we're on the 2nd of October. It's going to be a long few months ahead. How we motivate, I don't know really, other than actually in the COVID part of our ICU at the minute, it's, you know, it's quite, patients are getting better, you know, and that, you know, I guess we just have to use that. We are doing the right thing. We have to look after each other. We have to be kind to each other. You know, we have to work as a team and look after each other. We have to make sure we have our downtime. We have to, you know, but yeah, to say it's going to be anything other than a long, hard winter.
No, but, yeah.
There's just one more question here about steroids as well. So I'm not sure who it is, but the body's reaction identifies the severity of the illness. Do you use steroids frequently if second wave occurs?
So I think the research has started to show that for moderate and severe COVID pneumonia, dexamethasone is now licensed and is out there to be used. That was one of the first things that came out of the trial. I think right from the start, when we started to look at a few CT scans and stuff, we all had an inkling that steroids was potentially a way forward. But I think this was a disease that we had never managed before. And so we all sort of looked at these x-rays and said, oh, it looks like this. And when we've experienced patients that have behaved like this in the past, steroids will be good. And I think we all felt like we wanted to use them. But recently that evidence has come out that dexamethasone, orally or IV, as early as possible in moderate to severe cases, will most likely do benefit without causing any significant harm. And I think that was always the fear with any trial drug is we think that, you know, these drugs will likely do some good, but actually have never met them before in terms of the COVID disease. Is it going to do any harm? And are we going to end up giving something that would cause more harm? So yes, steroids in the next wave is now in our SOP for COVID pneumonia.
Okay, well, thank you very much. It's been fascinating, and if you're online with us at the moment and you missed the first part, the recording from today's session will be available later on this afternoon. So please do share with colleagues who haven't maybe been able to join us today. So just a big thank you. I know it's new experience doing these things on Microsoft Teams Live. I think you've been a great double act, and it's been really good to hear from you. Thank you. Goodbye, everybody.
Cheers. Thank you.